Hello everyone, welcome to my channel. Today we are going to be looking at anatomy of the spinal cord, neuroanatomy. So by the end of this video, you'll be able to describe the external gross anatomy of the spinal cord, including the extent, the enlargements, and the meningeal coverings. You'll be able to identify 31 spinal segments and explain the difference between the vertebral and spinal cord levels. Be able to explain the internal organization of the spinal cord, distinguishing the gray matter from the white matter. You'll be able to trace the major ascending sensory and descending motor pathways. You'll be able to relate the spinal cord lesions to expected clinical deficits, for example, Brown-Séquard syndrome. So now, the spinal cord, as you can see in this image, has we have cervical, 8 cervical nerve pairs, 12 thoracic nerve pairs, 5 lumbar nerve pairs, 5 caudal nerve pairs. We also have the caudal equina, and spinal cord is covered by meninges, the arachnoid, the pia mater, the arachnoid matter, and the dura mater. From outside to inside, we have the dura mater, the arachnoid mater, and the pia mater. Remember, we said the mnemonic is DAP. We are naming them from outside to inside. So let's look at the external anatomy of the spinal cord. The spinal cord is located in the vertebral canal. If you have not seen the vertebral canal, please watch our video on the vertebral column. We'll discuss that extensively on the vertebral column, so please do. I'll drop the link in the description box so that you check it out. So it extends from the foramen magnum, which is continuous with the medulla oblongata, to the level of L1 to L2 in adults, while for neonates or for newborns it extends to L3. We have the conus medullaris, which is a tapered inferior end at the level of L1 to L2. Let me be showing you these images. So from foramen ovale, we do not have the conus medullaris, which is a tapered end. So this is our conus medullaris. These are conus medullaris. The tapered end, conus medullaris, which is at the L1, L2 region. We have the caudal equina, which is the lumbar and sacral nerve roots descending from the conus. We also have the filum terminale, which is a pia mater extension anchoring the cord to the coccyx. It's a pia mater extension. Filum terminale is a pia mater extension. Common MCQ question. So the caudal equina, we said, is the lumbar and sacral nerve roots descending from the conus. So you see them. Call them the caudal equina, collection of nerves, the tail of a horse. That's where the name caudal equina was gotten from, tail of a horse. If you have seen the tail of a horse, that's how caudal equina looks. So the segments of the spinal cord and its enlargements, we have 31 segments. Like we said, we have 8 cervical, C1 to C8. We have 12 thoracic, T1 to T12. We have 5 lumbar, L1 to L5. We have 5 sacral, S1 to S5, and we have 1 coccygeal. And the cervical enlargement, we have the cervical enlargement, which is L4 to T1, which innervates the upper limbs. From the cervical enlargements, that's where we have the brachial plexus. The lumbosacral enlargements innervates the lower limb. That's where we have the lumbosacral plexus. So we have cervical enlargements, we have lumbar enlargements, conus medullaris here, and medulla oblongata. 2 major enlargements. So the meninges, the coverings of the spinal cord from outer to inner. Remember, we said the mnemonic is what? DAP. The dura mater, the arachnoid mater, and the pia mater. The dura mater is tough. It's a tough outer sac. Has an epidural space which contains fat and veins lie outside. We also have the arachnoid mater, which is delicate, web-like, and has a subarachnoid space that contains cerebrospinal fluid. We have the pia mater, which is adherent to the spinal cord and has the denticulate ligaments, which are tooth-like. They are tooth-like projections from the spinal cord, from the pia mater. They extend from the pia to the dura to anchor the spinal cord. They are tooth-like in nature. So we looking at the internal anatomy of the spinal cord, and we're going to start with the gray matter, which is this butterfly shaped structure you're seeing here. So on cross section, when you take a cross section of the spinal cord, you will see that the gray matter is shaped like a butterfly, or some sources say it is H-shaped. If you look at it, some sources say it is H-shaped, and has a central canal. If you look at this image, you see a central canal which is opening here. Have a central canal which is lined by ependyma, central canal lined by ependyma. Divisions of the gray matter: we have a dorsal horn, which is this. We have, which is responsible for sensory processing. We have the ventral or anterior horn, which is for motor neurons to the skeletal muscles, and we have the lateral horn, as you can see here, tiny. So you have a lateral horn, which is present in the T1 L1 sympathetic and S2 S4 parasympathetic. So we have it at T1 to L1 and S2 to S4. So there are key nuclei cell groups in this gray matter. So we have nuclei cell groups in the posterior horn, and we have nuclei cell groups in the anterior horn as well as the lateral horn. So for the posterior horn, they will going to be looking at the major ones. For the posterior horn, we have the substantia gelatinosa, as you can see here, substantia gelatinosa. We also have the posterior marginal nucleus, but you're going to be looking more at the substantia gelatinosa, responsible for sensations like pain and temperature. That's the synapse site for pain and temperature sensations in the spinal cord. We have the nucleus proprius, which is for fine touch and pressure. Fine touch and pressure is at the nucleus proprius. We have the Clarke's nucleus. Some sources call it the nucleus dorsalis of Clarke, the nucleus dorsalis or the Clarke's nucleus. It's responsible for unconscious proprioception. Unconscious proprioception. So going to the anterior horn, we already finished with the posterior horn, and we are going to the anterior horn of the spinal cord. We have the alpha motor neuron as well as the gamma motor neurons. Remember, we said the motor neurons are in the anterior part to motor and skeletal muscle control. So the alpha motor neurons, they're responsible for extraocular muscle contraction, muscles of the eyes, while for the gamma motor neurons, they have muscle spindle sensitivity. So we have the nuclear group of the anterior horn nuclei here. So we have the lateral horn, which we said is autonomic, and the nucleus here is the intermediolateral cell column, T1 to L2, intermediolateral. Some sources will also tell you have the intermediolateral nucleus and intermedial nucleus. So intermediolateral and intermedial nucleus, they are responsible for preganglionic sympathetic neurons. That's their function. Preganglionic sympathetic neurons. That's the function they serve. So looking at the internal anatomy, we already talked about the gray matter, which you said is H-shaped, and we have described the posterior horn, the lateral horn, and the anterior horn, as well as the nucleus located in these regions and the functions they perform, the major nuclei and the functions they perform. Now, looking at the internal anatomy, we look at the white matter, which is composed of myelinated axons organized into columns or funiculi. They are organized into columns or funiculi. So if you look at this, you see that we still have our gray matter here, which we said is H-shaped or butterfly shaped. Now every other thing outside this, we have our white matter. Now white matter is divided into three parts as well. We have the posterior funiculus, as you can see here. We have the lateral funiculus, as you can see here, and we have the anterior funiculus, as you can see here. So our white matter divided into a posterior funiculus, an anterior funiculus, and a lateral funiculus. Now if you look at this image, you see the dorsal white column. Remember we say the funiculus are also called the columns. So this is the posterior, this is our lateral, and this is our anterior, and here we have our gray matter, which is H-shaped, the central canal here. Good. So if you look at this image, you see that we have pathways or tracts which are coded or colored blue, and some are colored red. So for those colored blue, they are the ascending tracts. For those colored red, they are the descending tracts. Now if in the spinal cord, the tract move through the white matter. When you take a cross section, it moves through the white matter part of the spinal cord, because we said they are what? They are myelinated. From the name white, they are myelinated. You know, white matter, we say they are myelinated. That means they contain the myelin sheet, and you know myelin is made up of majorly lipids, so they have this white appearance, unlike the gray matter, which has a gray appearance. So the white matter contains tracts, ascending and descending tract. Ascending tract are sensory tracts or sensory pathways. Descending pathways are motor pathways. So let's take a look at the major ascending sensory tracts. We have the spinothalamic tract, which is divided into a lateral spinothalamic and an anterior spinothalamic. The lateral spinothalamic is for pain and temperature sensation. Please don't forget this information. Lateral spinothalamic, pain and temperature sensation. Anterior spinothalamic, light or crude touch pressure. If you can possible, you write it down, get a notebook, write this information down. They will now have the spinothalamic. The spinothalamic, as you can see, this is the ventral, the the ventral spinothalamic tract and the lateral spinothalamic tract. The lateral spinothalamic tract is in the lateral funiculus. The ventral spinothalamic tract is in the ventral or anterior funiculus. So that's that about that. So if you look at that, so we have the dorsal column system, which is what you have here. The dorsal white column is it contains the fasciculus gracilis for fine touch proprioception, as well as 2-point discrimination, as well as fasciculus cuneatus. So both these are nuclei that are found, the fasciculus that are found in the dorsal column. They have fine touch proprioception, 2-point discrimination. 2-point discrimination, what we mean by that is if you are the ability to discriminate 2 points on the body. If you are touched, if a needle is placed on the surface of your skin at 2 different points, how close will you bring this needle so that you'll be able to differentiate that yes, it is 2 different points. There's how close you bring the needles, even though they're not on the same point. The excuse me, the patient will say they're having sensation just on 1 point. So how well you can discriminate 2 points, called 2-point discrimination. We also have the spinocerebellar tract, which will have the anterior and the dorsal. This is the dorsal spinocerebellar and the ventral spinocerebellar. And they're responsible for movement and position mechanism. We have the spinotectal, which is afferent information for spinovisual reflexes and brings about movement of the eyes and head towards the source of stimulation. If you're sitting in a room and you hear a sound behind, immediately reflex, your head turns backwards. So that is the function of the spinotectal tract. We have the spinoreticular tract for deep and chronic pain. Spinal olivary tract for it conveys information to the cerebellum from cutaneous and proprioceptive organs. So let's now look at the major descending tract, which are the motor tracts. The descending tract will have the lateral corticospinal, which is pyramidal, very, very important. It's for fine motor function and modulation of sensory function. We have the anterior corticospinal tract, which we have the lateral corticospinal and anterior corticospinal. Anterior corticospinal for gross and postural motor function. We have the rubrospinal tract, which is also for motor function, facilitates the activities of the flexor muscles and inhibits activities of the extensor or anti-gravity muscles. We have the vestibulospinal tract, which is for postural reflexes, and it facilitates the activity of extensor muscles and inhibits the activity of flexor muscles in association with maintenance of balance. We have the reticulospinal for modulation of sensory transmission, especially pain, modulation of spinal reflexes, and it influences voluntary movement and reflex activity. We have the tectospinal tract, which reflects head turning, as I explained earlier, concerned the reflex postural movement in response to visual stimuli. And we also have the descending autonomic tract for modulation of autonomic function, and it controls sympathetic and parasympathetic systems. We have the medial longitudinal fasciculus, which is responsible for coordination of head and eye movements. So, blood supply of the spinal cord. The arterial blood supply of the spinal cord has one anterior spinal artery and two posterior spinal arteries. One anterior spinal artery and two posterior spinal arteries. The anterior spinal artery supplies the anterior two-thirds of the spinal cord. Remember, we said the anterior horn contains motor nuclei. So definitely you're going to be having the motor and spinothalamic tract are being supplied by the anterior spinal artery. And if there's an occlusion of this artery, you're most likely going to have motor deficit. We now have the two posterior spinal arteries that supply the dorsal column, which is a sensory pathway, and the posterior horns of the spinal cord, which is where you have the sensory nuclei. So it supplies the posterior one-third of the spinal cord. So there's an occlusion of this artery, you're mostly going to have sensory defects. Then we now have the radicular arteries. The radicular arteries, artery of Adam, for example, the artery of Adam Kewit, they reinforce from the aorta. Yes. So we have the posterior spinal arteries, which you said there are two, and there's one anterior spinal artery, and we have the radicular arteries, posterior radicular, anterior radicular arteries. They also supply the spinal cord. For venous drainage, we have the 6 longitudinal channels that drain into the internal vertebral venous plexus. Drain into the internal vertebral venous plexuses. So we're going to look at clinical correlations now. What are the clinical correlates of importance? We have anterior spinal artery syndrome. Remember, I said the anterior spinal artery supplies anterior two-thirds of the spinal cord. So if there's an occlusion of the anterior spinal artery, there's going to be loss of motor function as well as pain and temperature sensation below the lesion, but preserved proprioception and vibration. The proprioception and vibration, we said, is by the dorsal column, and it is preserved in this case. So proprioception and vibration is going to be preserved, but pain and temperature sensation as well as motor function is lost. Remember, the pain, spinothalamic fibers cross in the anterior white commissure. They cross in the anterior white commissure, so they'll be affected as well. So there's loss of pain and temperature sensation below the level of lesion. We have Brown-Séquard syndrome. Brown-Séquard syndrome is a hemisection. It's a hemisection in the spinal cord. It could be as a result of a gunshot wound. It could be as a result of a knife wound, but there's a hemisection of the spinal cord. So half, as you can see in this image, half of the spinal cord is affected. So all the tract on one side of the spinal cord are affected. So there's going to be defect in the motor function as well as sensory function below the level of lesion. So for the sensory function, we are going to have the loss of sensation is going to be ipsilateral, specifically for loss of proprioception and vibration. Also for the motor function is going to be ipsilateral on the same side of the lesion, but for pain and temperature sensation is going to be contralateral, because remember, as I said here, we have the spinothalamic tract crossing to the other side. So this is spinothalamic tract. Let's say this is spinothalamic tract from the left side, and this is spinothalamic tract from the right side. So, and there's a lesion on this side. That means you're going to have loss of sensation for the tract coming from the opposite side, the contralateral side. So it's going to be loss of sensation on the contralateral, loss of pain and temperature sensation on the contralateral side below the level of lesion. We also have syringomyelia. Syringomyelia is a fluid cavity in the central cord, often at the level of C8 to T1. It disrupts the anterior white commissure, which I already mentioned, and there's going to be what? Loss of pain and temperature sensation. The moment you hear anterior white commissure affectation, know that there's going to be loss of pain and temperature sensation, because the spinal thalamic tract, remember, if you go backward, you see that we said the spinal thalamic tract are for pain and specifically the lateral spinal thalamic is for pain and temperature, and they're found in this anterior white commissure. So anytime there's an affectation around the anterior white commissure, anywhere here, you're going to have defect with the pain and temperature sensation, but loss of pain and temperature sensation, but preserved fine touch and what? Proprioception. There's preserved fine touch and proprioception in syringomyelia. Now this is syringomyelia, where you are having presence of a syrinx here. So syringomyelia is a cyst or a cavity formation within the spinal cord. See, a cyst or a cavity within the spinal cord. So it expands and elongates over time. It gives a cape-like distribution. This is what we refer to as cape-like distribution. It gives a cape-like distribution. So there's loss of pain and temperature sensation in the upper extremities and preserved light touch and proprioception. Why is light touch and proprioception preserved? Because the dorsal column, which contains which is responsible for fine touch and proprioception, is not affected. So that is why. But if you look at the lateral spinothalamic tract, look at this, passes in the anterior white commissure and goes like this, so it is affected. So there's going to be bilateral loss of pain and temperature sensation. So thank you for watching. Don't forget to like, share and subscribe to Alacrity Explains Anatomy for more anatomy videos. Thank you for watching.